So, go ahead, ma'am.
Good afternoon, everyone. Myself, Dr. Shweta Sonwalkar, Clinical Head and Fertility Specialist at Oasis Fertility, Belagavi. Today, I am dealing with unexplained infertility. Unexplained in the sense when we do infertility workup in an infertile couple, that is basic investigations like when we do ultrasonography, any pathologies in the uterus or any pathology in the ovaries or number of follicles in the ovaries, everything looks normal. And even when we do the tubal patency test, that is hysterosalpingography, both the fallopian tubes looks open and patent. And when we do semen analysis, in that also semen parameters all looks normal, but still the patients are not conceiving. So this is called unexplained. There is no explanation for the infertility couple. So how we can go further in such cases? Let us see in further slides. I'll be explaining regarding what are the causes and what treatment the patient should undergo. So unexplained infertility, according to ASRM, it is a diagnosis with exclusion. That is the demonstration of at least one patent fallopian tube should be present, and documentation of ovulation of a female partner is present, and semen analysis with adequate number of motile sperms for the male partner. Everything seems normal. So we are excluding all these parameters, and then the diagnosis is made regarding unexplained infertility. And according to ICMART, infertility in couples with apparently normal ovarian function, fallopian tubes, uterus, cervix, and pelvis, and with adequate coital frequency, and apparently normal testicular function, genitourinary anatomy, and normal ejaculate. The incidence being it accounts for 25% of infertile couple. So diagnosis of unexplained infertility was ruled out as long as the ovulation is confirmed. But even apparently normally ovulating woman, she might not produce poor quality oocytes. She might produce poor quality oocytes or embryos. And even tubal patency has been proven. But patent fallopian tubes, it does not necessarily function normally, and semen analysis is normal, but the fertilization potential of the sperms can be affected. So, what could be the causes and what are the etiologies which comes under male unexplained and female unexplained infertility? Let us see what are the etiological factors in male partner. So male partner who have a normal medical history, normal physical examination, and a semen analysis report as normal, with no female factor identified. So the possible factors could be advanced paternal age, lifestyle factors, oxidative stress, then immune fertility, sperm DNA damage, genetic defects. So let us see one by one in detail regarding the etiology. Male unexplained infertility. The normal sperm has got three different parts, that is head, midpiece and the tail. And the head has got the membranes, that is acrosome membrane, plasma membrane, and the head contains DNA, the integrity of which is normal in normal sperms. And even reactive oxygen species are of low quality. And the neck piece contains mitochondrial membrane with high activities and high, which accounts for high sperm motility. But in abnormal sperms, the integrity of the acrosome membrane, plasma membrane, and DNA fragmentation, everything will be altered. So, what are the causes which causes alteration in these sperms? Are advanced paternal age. As the male ages more than 45 years, the quality and the quantity of the semen gets affected, and there is more mitotic divisions within the germ cells, resulting in elevated levels of DNA damage with age, and also the possibility of development of new single gene mutations due to defect in DNA replication and epigenetic changes due to defect in DNA methylation is present. And lifestyle, it accounts very important in cases of male infertility, such as a person who is exposed to higher temperature and radiation exposure and obesity, alcohol consumption, tobacco chewing, then use of recreational drugs, uh, wearing a tight-fitting underwear, and recurrent hot baths and saunas, use of pesticide residues. These all accounts for these all affect the Leydig cells and decreases the testosterone level, and also it the seminiferous tubules are affected, which leads to decrease in the sperm motility, sperm morphology, uh, leading to in unex- leading to infertility in the male. All these conditions which causes oxidative stress in the sperms. Oxidative stress in the sense the reactive oxygen species present a broad category of molecules that are the byproducts of oxidative metabolism. These ROS in small amounts, they play a physiological role in capacitation, hyperactivation, motility, and fertilization. But reactive oxygen species may also have a role in regulation of nuclear maturation in the spermatozoa. But elevated levels of this reactive oxygen species can overwhelm the body's natural antioxidant defense mechanism and lead to damage of lipids, proteins, and DNA of the spermatozoa, and a condition called oxidative stress, leading to reduced sperm motility and morphology. So all these reactive oxygen species which causes oxidative stress decreases the DNA damage, and low sperm count, low sperm motility, and low sperm volume is seen in infertile male. So, what are the immune causes for male infertility? They are developmental abnormalities in the blood testis barrier and blood epididymal barrier. They may cause weakness, damage, and disruption of the membrane. This leads to appearance of anti-sperm antibodies. These anti-sperm antibodies, they belong almost exclusively to the class G and A, and namely IgG and IgA. These both immunoglobulin classes can be detected on the surface of the sperm cells or in biological fluids. IgA isotype found in the mucosal surfaces and secretions, it has an essential role in the protection from several external agents such as toxins, virus, and bacteria. The most documented effects are their capacity to reduce the sperm motility, causing sperm agglutination and impair the sperm ability to penetrate the cervical mucus, and the sperm egg interactions, leading to infertility. Then, abnormal sperm oocyte interaction. This process of fertilization commences with capacitation, which occurs in vivo during the travel of sperm through the female genital tract. But in vitro, it can be induced by removal of the seminal plasma and addition of the culture media. This prepares the sperm cell to undergo acrosomal reaction. The physiological mechanism is an increased intracellular calcium entry through the sperm calcium channels called Caspar 1 to 4. Individuals with mutated Caspar 1 gene are infertile with poor hyperactivation response despite normal count, motility, and morphology. So, sperm binding to zona pellucida is a crucial step in fertilization. Defect in zona pellucida binding has been observed in 15% of infertile men with normal semen. If acrosome reaction occurs in the sperm before zona pellucida binding, it would be unable to bind or penetrate the zona pellucida. So, in summary, the causes of male infertility are fertilization defects, oxidative stress, and sperm DNA damage, immune infertility, and genetic defects. These are the main causes of unexplained infertility in male. Coming to female unexplained infertility, certain pathologies identified or unidentified. They are maybe responsible. Some are putative, subtle, or uncertain, and the causes might be from ovarian causes, endocrine factors, peritoneal factors, tubal factors, endometrial factors, cervical, embryological factors, and psychological factors. And here again, the lifestyle is one of the most related risk factors is obesity. As the hypercaloric diet alters the energy state, which influences the metabolic processes of the body, which indirectly targets the hypothalamic pituitary gonadal axis at the level of the central nervous system, affecting the GnRH pulse. And other lifestyle factors such as disturbed circadian rhythm, then smoking, alcohol consumption, use of recreational drugs, then recreational chemical and pesticide exposure, radiation, all these leads to decrease in the ovarian uh, ovarian response, leading to decrease in the quality of the oocytes. Then subtle ovarian disorders, it is defined as an ovulation, inadequately timed ovulation, or ovulation of a follicle of reduced size in regularly menstruating women, and premature ovarian aging. Ovarian reserve, generally defined as number of oocytes remaining in the ovaries, may also influence the chances of conception. Being closely linked to age, the ovarian reserve decreases with age. Ovarian aging, which leads to poor ovarian response and poor follicular growth, may also contribute to unexplained infertility, that is female subfertility. Then undiagnosed tubal factors, tubal peristalsis and the internal milieu are, are critical to fertilization and normal implantation of the embryo. So, disruption of functional integrity of the fallopian tubes can lead to unexplained infertility. And the causes being contributing factors like cigarette smoking decreases the tubal motility and changes the tubal microenvironment, thus affecting the tubal motility, structure, and blood flow, as well as the oocyte capture by the fimbria. And another contributing factors are infections, that is pelvic inflammatory diseases, and any inflammation anywhere in the body that impairs uh, folliculogenesis, then maturation and fertilization, then it increases the reactive oxygen species, leading to DNA damage to the oocyte, sperm, and endometrial cells, and impaired residualization and embryo attachment in the uterus. So, female causes like cervical factors, altered cervical mucus, then immunological factors, that is anti-sperm antibody which is present in the cervical mucus, also affects the transport of sperm into the uterine cavity. Then endometrial factors, which includes non-receptive endometrium due to altered gene expression, uterine perfusion problems, abnormal secretion of endometrial proteins, abnormal integrin and adhesion molecules which are present in the endometrial cavity, and presence of abnormal T cells and NK cells activity. And tubal factors, again, as I explained, abnormal peristaltic movements, that is bidirectional movements, loss of ciliary activity of the cells inside the lumen of fallopian tube, which again leads to minimal hydrosulfins, which are not detected by ultrasonography. And ovarian and endocrine factors like increased phagocytic activity of the peritoneal leukocytes, which engulf the ovum or the sperm. Then minimal endometriosis, which are not detected by ultrasonography. Then antibodies to the zona pellucida, hypersecretion of luteinizing hormone and prolactin. Peritoneal factors include abnormal ovarian folliculogenesis, luteinized unruptured follicles, genetic or cytological oocyte abnormalities, then poor quality oocyte and increased age. Immunological factors like autoimmune disorders, autoimmune thyroiditis and APLA, autoantibodies towards ovarian antigens leading to premature ovarian failure. So the investigations in male infertility, according to ESHRE 2022, WHO semen analysis, if the semen analysis is normal, then the following investigations are not recommended, like testicular imaging, testing for anti-sperm antibodies in the semen, then sperm DNA fragmentation, chromatin condensation test, sperm aneuploidy screening, then serum hormonal testing, HPV testing, and microbiology testing. These are all not recommended if the semen analysis is normal. Then investigation for female infertility includes hormonal assays on day 2 of the cycles like FSH, LH, AMH, TSH, and serum prolactin. Ovarian reserve testing like AMH, then antral follicle count, FSH. Uterine cavity assessment is done by transvaginal ultrasonography and 3D ultrasound. Then tubal patency test by hysterosalpingography, hysterosalpingo contrast sonography, or laparoscopy. Then ovulation studies are done by scan like follicular monitoring and serum progesterone. According to ESHRE 2022, ultrasound, preferably 3D ultrasound, is recommended to exclude the uterine anomalies in women with unexplained infertility. MRI is not recommended as a first line test to confirm a normal uterine structure and anatomy in women with unexplained infertility. If ultrasound assessment of the uterine cavity is normal, no further evaluation is needed. And other tests like tests for thyroid antibody, testing for thrombophilia, then measurement of oxidative stress, genetic and genome tests, vitamin D deficiency. If TSH is normal, additional thyroid evaluation, they are not recommended in female infertility. TSH measurement is considered good practice in preconception care, and BMI evaluation in the female is considered a good practice in preconception care. Then confirmation of the ovulation in women with regular menstrual cycles. Test for confirmation of ovulation is not routinely recommended. In women with regular menstrual cycles, if confirmation of ovulation is warranted, urinary LH measurements, ultrasound monitoring, or mid-luteal progesterone measurements can be used. Then role of laparoscopy. Routine diagnostic laparoscopy is not recommended for the diagnosis of unexplained infertility. but it is indicated in cases like if there is a suspicion of pelvic pathology such as endometriosis, pelvic inflammatory diseases from any like taking a history pelvic examination and in ultrasound, then laparoscopy is indicated. Then avoiding diagnostic laparoscopy for tubal evaluation in cases of if the patient is more than 40 years, if the patient has decreased or poor ovarian reserve, and male factor infertility, laparoscopy is avoided. Management of unexplained infertility, there are different modalities of treatment. Treatment options like expectant management, ovulation induction with timed intercourse, then natural cycle with IUI, ovulation induction with IUI, IVF or ICSI. Let us see who are the couples in whom expected management is recommended according to NICE and RCOG 2013. 2 years of expectant management prior to offering IVF is recommended in cases of female aged less than 35 years age and married for less than 3 years of infertility. Expectant management is done for 6 to 12 months, and if the age is more than 35 years and if the couples are married for more than 3 years, then aggressive management is recommended. So management expectant therapy in cases of less than 35 years of age. After 3 years, 60% will conceive spontaneously, and after 5 years, chances of 80% chances of conception is present. And aggressive therapy for more than 35 years of age, married for more than 3 years of infertility is recommended. And ASRM does not recommend the use of clomiphene citrate or letrozole with timed intercourse because in unexplained infertility, expectant management without the use of ovulation induction is same as not using the oral ovulations. And HD22, he recommends IUI with ovarian stimulation. It is recommended as a first line treatment for couples with unexplained infertility. Intrauterine insemination in natural cycle IUI. It does not offer any benefit over the expectant management and it should not be offered in case of unexplained infertility. IUI with oral agents is an appropriate treatment in couples with unexplained infertility and it is more effective than expectant management. Either letrozole or clomiphene citrate can be used for IUI with uh, oral agents. Gonadotropin and IUI can be offered to a couple with unexplained infertility, which is a level B evidence. Patients should be aware that gonadotropin and IUI is associated with higher pregnancy rate per cycle and higher multiple pregnancy rate per cycle than IUI with oral agents. Then IVF ASRM 2020, it is recommended that couples with unexplained infertility initially undergo a course typically 3 to 4 cycles of ovarian stimulation with IUI with oral agents. For those unsuccessful with ovulation induction with gonadotropin, IUI treatment, IVF is recommended. Then IVF should be offered to couples with unexplained infertility after 3 cycles of ovarian stimulation and IUI have failed. IVF can be offered as an effective first-line treatment in unexplained infertility. There is insufficient evidence to recommend the routine addition of ICSI in couples undergoing IVF to increase the live birth rate. And according to NICE 2013, IVF has been recommended for all the patients who failed to conceive after expectant treatment for a period of 2 years. So, protocol for management for unexplained infertility to be summarized, like if the patient age is less than 35 years of age and if she is married for less than 2 years, expectant management for up to 2 years. Then, if patient does not conceive, then ovulation induction with HMG or oral ovulation, and if for at least 3 cycles, if patient is not conceived, then later on IVF is recommended. But less than 35 years of age and married for more than 2 years, then the expectant management is not recommended. Directly ovulation induction with HMG and IUI for 3 to 4 cycles. Later on IVF is recommended. If the patient is between 35 to 39 years, if even if they are married for more than 1 year, uh, then HMG stimulated IUI for 3 cycles. If patient does not conceive, then IVF is recommended. But if the patient is more than 40 years of age, irrespective of the duration of the marriage, ovulation induction and directly IVF is recommended in such patients. And non-pharmacological therapies such as avoiding cessation of smoking, then limited caffeine intake to 250 milligrams per day, then limit the alcohol consumption to 4 drinks per week, maintain the healthy body weight, like ideal body mass index for both the partners between 19 to 25 kg per square meter, then daily physical activity including aerobic exercises, changes in the dietary habits, that is high intake of low glycemic index food, protein intake more so from vegetables based than animal sources, fat intake from dairy products and iron intake. Avoid testicular heat exposure by use of loose cotton underwear by men and avoiding use of laptops on lab for long durations. Then avoid prolonged use of electric devices. So these are the non-pharmacological therapies the patient should consider. Uh, then to summarize regarding unexplained infertility, it is a diagnosis with exclusion and female evaluations on date of the cycles, hormonal evaluation, cavity assessment by ultrasonography and 3D ultrasound, patency of the tubes by HSG is routinely done. And in the absence of evidence for tubal or other pathology, laparoscopy is not warranted in unexplained infertility. However, there may be a place for diagnostic laparoscopy in young women with long period over more than 3 years of marriage, uh, 3 years of infertility, but no recognized abnormalities is found. Then laparoscopy is indicated. Then expectant management is considered as a good practice, good prognosis patients, and lifestyle modification plays a pivotal role in expectant management of patients with unexplained infertility. No role of ovulation induction and timed intercourse and natural cycle IUI in the management of unexplained infertility. Then couples with unexplained infertility can undergo 3 to 4 cycles of ovarian stimulation with IUI with oral agents. Gonadotrophins can be used while following strict cancellation criteria, that is more than 3 follicles. If they are present, we have to cancel the cycle because the risk of multiple pregnancy. And for those unsuccessful with ovarian stimulation and IUI treatments, IVF is recommended. And for more than 38 years of age, direct IVF is the recommendation. Thank you. Any questions? I am free to answer. Does IVF work for unexplained infertility? Yes, of course. IVF in cases of more than 35 years of age and married for more than 3 years, and with failed IUI cycles, at least 3 to 4 cycles of IUI, and more than 40 years of the age, direct IVF is recommended, and it will definitely work in case of unexplained infertility. Thank you.